So, good morning, everybody. I'm happy to introduce Carmen Pottenken, who will talk about microsatellite instability and CRC, and we hope to be able to enlighten a little bit this quite complex topic. Thank you very much.
So as you already heard, the topic of today's talk is about microsatellite instability and colorectal cancer. First, we're going to have a few definitions, a short overview about the colorectal pathogenesis. Then we were talking about microsatellite instability, clinical manifestations, hereditary versus sporadic appearance, the diagnostics, prognostic implications, and in the end, we will have a short look at therapy. So, sometimes we get pathologic reports like this, and we read DNA mismatch repair protein, expression, loss of expression, no expression of BRAF gene, and maybe some of my colleagues are wondering, actually, what are these pathologists even talking about? So I just want to raise a question, and I want you to put your hands up, make a little morning stretch. Who thinks microsatellite instability is a good thing or a bad thing, or if you're having colorectal cancer, it depends on the staging. So who of you thinks if you have a colorectal cancer with microsatellite instability, it's a bad thing? Okay, hands are raising, that's good. Who think actually it's a good thing? And who think it depends on stage? Okay, very good. So thank you. We will hopefully make things clearer today and make the whole topic a little better understood. So just short remember, maybe from the study that you're at university, you already know that steps in DNA mismatch repair, we have a mispairing in one of the bases of the DNA are adenine, thymine, guanine, and cytosine. If we have a mispairing, we have some systems like proteins and enzymes who are recognizing the wrong mispairing, and then they're recognizing it, and the new strand resynthesizes. DNA mismatches commonly occur in region of repetitive nucleotide sequences, and these are called microsatellites. So microsatellites are short tandem repeats, actually normally 2 to 6 nucleotides. And if we have a defect in a mismatch repair system, it leads to faster accumulation of genetic errors at microsatellites. The definition of microsatellite instability is the inability of these mismatch repair proteins to fix genetic errors at microsatellites. So as we see here, the microsatellite replication, if we have mismatch in the base, in translation and in transcription, we can have then variably allele size, which leads to total different proteins or silencing of genes. So a microsatellite instability affects genes that control cell growth, regulating apoptotic cell death regulation, and also DNA mismatch repair gene protections by itself. So actually it's like a circle. And the products we're talking about today is MLH1, PMS2, MSH2, and MSH6. Colorectal pathogenesis, we have two pathways, the chromosomal instability pathway and the microsatellite instability pathway. 85% of colorectal cancer are due to chromosomal instability, whereas 15% are due to microsatellite instability. Chromosomal instability pathway is due to an carcinoma sequence pathway. We know it refers to a pattern of mutational activation of oncogenes like KRAS, which are inactivating tumor suppressor genes like p53, and this leads to a microsatellite stable colorectal cancer. Whereas microsatellite instability is due to an inactivation of at least one of the 4 mismatch repair proteins genes, which are MLH1, MSI2, and 6, and PMS2, which lead to a microsatellite unstable colorectal cancer. So we will have a look at these pathways. We have a mutational inactivation of the mismatch repair system and an epigenetic inactivation. The mutational inactivation is a germline mutation, whereas the epigenetic inactivation is a local event in the tumor, and it's sporadic, it's non-inherited. But the germline mutation can lead to Lynch syndrome, also called HNPCC. Epigenetic inactivation, epi means above, so it's above genetics. Epigenetic variations include any processes that alters gene activity without changing in DNA sequences. We will have a look now at the germline mutation, HNPCC, and then about the epigenetic inactivation of the mismatch repaired genes. So HNPCC is hereditary non-polyposis colorectal cancer, also known as Lynch syndrome. It's an autosomal dominant disease. It's a germline mutation, as we already had in the mismatch repair genes. The lifetime risk for getting colorectal cancer is up to 70% in these patients, whereas normal population has a risk for 5.5. These patients also develop additional tumors like up there, the endometrium is involved, ovaries, small bowels, pancreatobiliary tract, gallbladder, skin. Patients with HNPCC tend to be 20 years younger than patients developing a sporadic colorectal cancer. As you already heard, the epigenetic changes in epigenetic DNA hypermethylation do not only involve changes in the actual DNA sequence, but they're leading to modifications in histones that compromise DNA methylation. So DNA methylation means that we have a cytosine where a methyl group CH3 is added, and then the cytosine changes due to deamination to thymine. So then we have a mispair, we have a TG mismatch, and this can lead to silencing of the MLH mismatch repair protein, and then we have, due to a methylation of the MLH promoter, it leads to microsatellite instability. So we have either the non-inherited pathway, like I just mentioned, the epigenetic DNA hypermethylation, and we had a look at the germline mutation. How do we differentiate between these two pathways? And why is it important? We have to perform an immunohistochemistry to have a look at the genes and the proteins. If there is no loss, this means no coloring, no staining, we have a microsatellite stable colorectal cancer. But if we have a loss of the MSH2, PMS2, or MSH6, we have a high suspicion for HNPCC associated colorectal cancer. If we have a loss of MLH1 and or PMS2, we can have either sporadic or a suspicion of HNPCC. And now it's important for us to distinguish if it's either a sporadic pathway or an HNPCC pathway. So how can we do this? How can we differentiate between these two pathways? Actually, it's known, it's an epidemiological fact that the BRAF gene mutation has never ever been observed in HNPCC so far. Actually, we don't know why, but it is like it is. And so a mutation in the BRAF gene in combination with the loss of the MSH2, MSH1 and PMS2 is the proof for sporadic microsatellite instability colorectal cancer. But, and there is always a but, it is important to know the absence of a BRAF mutation, like if we have a BRAF wild type, does not imply Lynch syndrome. So if we have colorectal cancer with the BRAF wild type and the loss of MLH1 PMS2, we have to perform further testing. So now a question to my colleagues, maybe a tricky one, but I think you will know. You already heard about it. How can we distinguish between an epigenetic, a sporadic MSI, CRC, or a germline mutation?
Maybe is it told before the hypermethylation?
Yes. Remember, very good. So a methylation of the MLH1 promoter test has then to be performed. So if we have a look at this slide now again, we have a loss of the MLH1 and or PMS2. We have to perform a BRAF testing. If we have a BRAF wild type, we have to perform promoter hypylation to distinguish either is it a sporadic pathway or a suspicion of HNPCC. So a short overview, and to sum this up. So immunohistochemistry testing with the 4-panel test. If the results for MLH1 is abnormal, make the BRAF testing. If it's negative, do the promoter hypermethylation test. If you have a suspicion for Lynch syndrome, you have to perform genetic testing of the germline DNA. But why is this so important? Do we even have to care? Yes, we have to care about this. MSH, MSI colorectal cancers, including sporadic and HNPCC, tend to have a less aggressive clinical behavior and a favorable prognosis. This phenomenon has been repeatedly observed in retrospective studies, large trial studies, and meta-analysis. So MSI tumors have a better prognosis in stage 1 and 2, or significantly have lower rates of lymph nodes and distant in metastasis, and they have a lower prevalence in metastasized disease. This is a big study from South Korea. They evaluated nearly 3,000 patients, and it also comprised with other findings in the literature. And it shows here on the X, we have the X-axis, we have the month. On the Y, we have the cumulative survival. The lighter line is the microsatellite instability colorectal cancer. The black one is the colorectal cancer sporadic. And in stage 1 and in stage 2, they had a better disease-free survival, also in stage 3. But due to decreased prevalence and also in the literature, actually there's less clear evidence for stage 3 and metastatic stage 4. So MSI has better prognosis, mainly in stage 1 and 2. For stage 3 and 4, we have less clear evidence. There are a lot of conflicting results. The underlying mechanism is not completely clear, but it has been suggested that the improved diagnosis of MSA maybe resulted from a pronounced anti-tumor immune response. Tumors are hypermutated and express abundant peptides, may serve as neoantigens, and they are eliciting an immune response by the abundant tumor-infiltrating lymphocytes, which leads to an active immune response to the tumor. And this is known as a prognostic factor. If we have a look at the grading algorithm, we see that microsatellite stable tumors of colorectal adenocarcinomas are high risk, whereas microsatellite instability tumors are always graded low risk. If there is a BRAF mutation, the tumors are graded as most aggressive. So of note, it is to mention that HNPCCs are always graded low grade because they are microsatellite unstable colorectal cancers. In the end, we talk about therapy. It's just the predictive implications. Data indicate that 5-FU chemotherapy is inactive in stage 2 cancer patients with MSI. This is consistent with preclinical data that is showing that mismatch repair deficiency is associated with 5-FU resistance in colorectal cancer cells. But the chemotherapy regimen of folinic acid, 5-FU, and oxaliplatin, also known as FOLFOX, is effective in cancer stage 3 and metastatic cancer. There is only limited data provided so far, but nevertheless, knowing the MSA status of the patient may help the oncologist to draw a personalized, appropriate treatment plan. Due to unstable and hypermethylated and hypermutational nature of the colorectal cancer, these tumors tend to express higher levels of checkpoint proteins like program death and program death ligand. And this makes the MSI tumors more responsive to immune therapy with PD-L1 blockage, especially in metastatic disease. So just to sum it up, the majority of MSI in colorectal cancer are sporadic cases due to the promoter hypylation It's a favorable prognostic biomarker, and the HMPCC is always a low-risk colorectal cancer because it's MSI. It has a predictive role for the resistance of 5FU and a predictive role for good response to immune therapy, especially in metastatic cancer. So I hope if you see in future pathologic report like this, you're like, okay, MSI, MSH6, I've heard about this. PMS2 and loss of MLH1, I know we have to perform a BRAF. Okay, and if in doubt, just remember this slide where we have the immune histochemical pathways. If there is a loss of the staining, it's microsatellite stable colorectal cancer. Otherwise, in this case, there is a suspicion of HMPC, and there we have to clarify with these two methods. I want to thank you all for your attention. Thank you very much.
Well, thank you very much for the interesting topic, and I hope we could enlighten a little bit the topic, because it is complex, but it's very important. It's very important to know that these patients with microsatellite unstable cancer do have a stage 4 stage better prognosis than microsatellite stable, that they only very rarely progress to a metastatic disease, but when they do, then there is a new therapy with the pembrolizumab or nivolumab with the checkpoint inhibitors, and those inhibitors were last year FDA approved, and they were for the first time in history of FDA. These drugs were approved. It's a so-called site-agnostic approval. So wherever you do have a tumor, if it is a colorectal or non-colorectal cancer, but it is microsatellite unstable, you can apply in a metastatic disease the immune therapy, and they show dramatic changes and dramatic complete responses in before heavily pretreated patients sometimes. Thank you.
Thank you very much. Very important topic, and clearly we have to learn biology. I mean, biology is clearly the master or the king of everything, and that certainly a switch, and we will see more and more that we need to understand with markers the good or bad prognostic. Now, just one question is that this is in primary cancer, the primary tumors that you look basically at that. What happened in, for example, lung or liver metastasis? Do you see sometimes this mutation in the metastasis but not in the primary tumor?
Yes and no. So I think sometimes you do, especially only in the single metastasis, and sometimes you don't.
Usually it's a germline mutation, as you showed, and I mean you can have a second hit or something, but it's very rarely.
So that, if we have the result of the primary colon tumor that has been resected before, there is absolutely no reason to do, because we don't do biopsy in the liver metastasis usually. So I think with the rarity of that, I think it will not justify a biopsy and change the treatment, at least with this marker.
Just a comment and 2 questions. So when I finished medical school, there was only one drug. This was 5FU. At this time, all these patients with microsatellite instability got the chemotherapy and had no benefit, only they had the side effects. So all this goes in personalized medicine, and I think we will see this more and more. 2 questions. What are exactly the figures of chromosomal versus microsatellite instability? What's the distribution? And second is, could you have both? Could you have a chromosomic as well as a microsatellite instability? And could perhaps a microsatellite instability, we know if you have this, it's associated with better prognosis, neutralize perhaps some bad prognosis of the chromosomal instability? Is there anything known?
Oh, well, so the sporadic microsatellite instability, it's 4 times higher the incidence than the Lynch syndrome. Of the 15% of patients with colorectal cancer who have microsatellite instability, 12% do have the sporadic instability, and 3% do have Lynch syndrome, the germline mutation. So this is much more higher, the incidence that you have only a local mutation in the tumor, the probability than having a germline mutation. And the coincidence of a germline mutation together with a sporadic, I must say I never heard about. I don't know if there are any data about that, if patients do have a coincidence of both local and sporadic. I just don't know. Did you ever heard about that?
Yeah, I mean, I can imagine that, of course, you can still acquire further mutations, so why not? But
why not, yeah, but I don't know.
I would just like to challenge your very first question. You said you have a better prognosis overall when you have a microsatellite instability. I'm not quite sure about that. If you have a 35-year-old patient with a stage 1 colorectal cancer who is not recognized as a Lynch syndrome carrier, he may get a segmental resection. His risk for recurrent cancer is about 4-fold higher than that of a sporadic cancer patient. So he will have a higher risk of another cancer in his lifetime. And maybe we need to answer this question first.
Thank you very much. So this is of course true. When you do not recognize a patient with a HNPCC, then you have the much higher lifetime risk for another or second cancer. But when we just look at the cancer, then it is cancer stage for stage. It is a better prognosis than the microsatellite stable colorectal cancer. So we just look at the single cancer and then the prognosis is better. But of course, you're completely right. You could also get the endometrial cancer. The cancer itself does have a better prognosis than the sporadic microsatellite stable cancer.
And I'm asking this because the points that were not touched on explicitly in this talk are about what to do with these findings. And the community is not quite consistent as to how you should approach a patient, a 35-year-old patient with newly diagnosed HNPCC or Lynch syndrome-related cancer. Should he undergo segmental colectomy? Should he undergo subtotal colectomy, ileorectal anastomosis? Any comments on this?
Yes, we are looking for the next lecture about HNPCC. Of course, there's a great discussion ongoing in the colorectal community about what should we do, how aggressive should we go for a total colectomy, or maybe just colonoscopy on a regular basis, at what age starts the colonoscopy. But I think it's really completely different right now. So I would just like to skip the answer for the next topic then, next lecture.
And then final comment from my side, I would just like to make people aware of what we do in Zurich, because the guidelines, the German guidelines state that you should do Amsterdam or Bethesda criteria on your patients, and if they're negative, you can stop. And that is not what we do in Zurich. What we do in Zurich is we do routine MSI testing, and if that turns out to be positive, we do we search for mutations. And so we are more thorough than what the guidelines state. And also that goes into therapy, but we can leave that up for the next discussion. But maybe you want to comment on what we do from a pathologic analysis standpoint.
Because that's a very good point. I'm sure you know that last year there has been introduced this new human research law, or how you call it, Humanes Forschungsgesetz. And of course, all efforts that are being done right now is like, how do we protect sensitive data, and how do we also handle sensitive data. And of course, by performing those immunohistochemical tests, we get kind of a hint on a germline mutation, which could be also kind of a critical information. And like since last year, this test, this MSI analysis, they fall into a gray zone, and we decided in our institution that we will go on testing those MSI, or this mismatch repair proteins, also because we test on a tumor and we don't test on the normal patient tissue, and because we get basically only a hint. So it's not really confirmed. All those patients that we suspect they have MSI or Lynch syndrome, they then go to genetic testing. So it's only a suspect. And how you mentioned also those Amsterdam and Bethesda, or revised Bethesda criteria, I mean, even with histology or location of the tumor, we can suspect a Lynch syndrome, or only with the anamnesis, I mean, you can suspect it somehow. And that's why we go on testing. And one other thing is that in the guidelines you have like as a second step, the BRAF mutation. And in our institution, we just go for promoter methylation because we can. But of course, a lot of smaller institutions, they cannot perform this test, so they first go for the BRAF mutation.
Thank you very much.